So good afternoon. My name is Sam Melville. I am a newly minted fourth-year medical student at the Keck School of Medicine. And today I'm going to be talking about Medicaid expansion and smoking cessation among low-income smokers. Just a disclosure there. So basically the background for my project kind of has its roots in the Affordable Care Act. So in 2010, federal government passed the Affordable Care Act, which allowed things like pre-existing conditions to be covered for people to stay on their parents' plan until they were 26. It notably also included a Medicaid expansion. So that which individuals between 100% of the poverty level and now 138% of the poverty level would have new access to Medicaid. Formerly, that was just under the 100% level. Unfortunately, in 2012, the Supreme Court ruled that states did not actually have to expand Medicaid. And so while being politically very inconvenient, depending on your politics, that actually allowed for a really interesting natural experiment to take place where we had access to people who lived in states with Medicaid expansion and states without that Medicaid expansion. A really interesting paper in 2019 came up with, looked at smoking, and this is something that I'm going to be looking at in this presentation between those two groups. And it actually found that there weren't really any major differences in smoking behavior between people who had new access to primary care and smoking cessation treatments and who didn't. The data used in my project comes from the tobacco use supplement to the current population survey. This is a pretty exhaustive survey of individuals in the United States. And that's just, that chart there is just a sort of an example of what we looked at, sort of data taken from 2011, 2015, and 2019. The expansion or not happening in 2014. In addition, we used a differences model to look at Medicaid expansion in smokers versus non-smokers. Basically what this method sort of tries to do is it creates, it looks at a control group over time against an experimental group over time and sort of looks at how each group has changed relative to the other. As you can see here, what you need to do to make this valid is you need to come up with a group of people to test the assumption that without the experimental treatment, that smoking rates or the underlying measured variables are going to basically change in similar ways over the period of time. This is kind of difficult with a very specific population that we use. So we kind of got creative when we used individuals with private insurance. And we thought that, you know, in a sense, right, between the 100 and 138% poverty level, those people could be reasonably compared to people with private insurance from their employer. And so here on the right, as you see the chart for that, and then sort of going, and I will only cover this briefly because we have limited time, but briefly, we did a couple of other additions like using state fixed effects. We recognize that there might be differences in smoking policy overall that may not be related to Medicaid. We looked at PAT cost data, so how the cost of a pack of cigarettes changes in between states. And then we also used a new federal poverty level calculation that tried to be more inclusive of multi-income households, multi-generational households, and same-sex couples. And this is just an example of the instrumental variables approach we use. So as you might be able to infer, right, there's going to be some confounding variables between having Medicaid and smoking status, risk tolerance, things like that. And so what we try to do is we try to craft our regressions so that we would avoid some of that endogeneity. This is the sort of visual representation of our data. So as you can see on the right, we kind of had a very surprising finding, which was that it turns out that the non-Medicaid expansion folks actually reported over time lower probability of self-identified smoking behavior compared to the Medicaid group. That's kind of counterintuitive, right? You'd think higher, more expansion to, or more access to primary care, more access to smoking cessation, drugs, counseling. You'd think that would be the opposite. And so just kind of looking at our data here again, we were actually able to say, and this was statistically significant, we found that, among someone who had Medicaid or no insurance, who is less than 138% of the poverty level, and who gained Medicaid coverage, was actually 15.6% more likely to be a self-identified smoker than someone in the non-Medicaid group. So in summary, what did we do in this study? So basically what we did was we looked at a previous paper that saw that there wasn't much difference in between smoking behaviors between the Medicaid and non-Medicaid expansion states, specifically in that cut of people that's less than 138% of the poverty level, who might newly get Medicaid coverage. And we looked at that, and we did sort of added some more stronger controls and some more years to that analysis now that we have data up until 2019. And we more or less found that to still be true, that there wasn't a whole lot of difference in smoking behavior when all these people had new access to primary care through Medicaid. And we wanted to explore what the possible reasons for that is. Now, there is some people out there who would say that might be due to moral hazard, that people who gained insurance through Medicaid now felt more able to take more risks. And unfortunately, that doesn't really, unfortunately, that doesn't really bear out in a lot of research to date on these kinds of subjects. Now, the income effect could be at play as well, right? People having more money in their pocket because some of their medical expenses are paid for now by the government might have more money to purchase cigarettes. So that might be an effect. But I think what we found to be the most likely reason for this is that there's a discrepancy between what Medicaid expansion was supposed to do and what it actually did for a lot of patients. And we're working on some more research right now that will look at the very serious discrepancies between states in the Medicaid expansion group on what actual treatments, smoking cessation drugs, and all of that Medicaid actually covers, and that those people actually had new access to, and whether there were actual public health initiatives in those states to try to be able to help those people get connected to those resources. Briefly, I think some obvious weaknesses to the study here are the limited number of years available. We'd love to do this analysis 20 years from now. And that, given all these controls and things like that, it's still an imperfect measurement to be looking at these two populations over time when there's so many things at play in a person's smoking status. So just, final thoughts here is basically this paper doesn't suggest that Medicaid expansion led to increased smoking. That's not what we're trying to say here. What we're trying to say is that maybe the Affordable Care Act and Medicaid expansion didn't have the desired effect, and that further research will be required to do that. And I think in general, it's important to sort of remember that policy requires honing in on what actually will impact the people, and it requires a lot of research. And so just because you don't succeed at first doesn't mean we can't strengthen the ACA moving forward to be able to help more people who are smoking. And that's it. Thank you. Any questions? Yeah.
Just for the people who are on Zoom.
Hello? Okay, there we go. I just was hoping to get clarity. So the comparison group were individuals in Medicaid in states where there was or where there was not Medicaid expansion, but these were folks who were who had insurance through their employer, right?
Yeah, so because you're looking at groups both in Medicaid expansion and non-Medicaid expansion, you sort of need a parallel population where you can compare if there were changes in smoking behavior that weren't related to anyone who might be affected by Medicaid expansion.
Right, and they were also 100 to 138% of the federal poverty level,
Yeah.
the comparison group?
No, so they weren't. And that's a good point, right? It's like there weren't enough people to do that comparison. And
Yeah.
so, yeah, there are going to be some differences definitely in smoking behavior between those groups. I think it's important to remember that, the parallel trends assumption is more based on how they change over time rather than where they started at, right?
Okay.
And so mainly what that tried to measure was differences between the states in policy and likelihood of smoking behavior over time.
Okay,
The states.
yeah, because I was just wondering if this could also, yeah, like you mentioned that there's obviously potential confounding, and it seems like I'm curious about, whether you think that there would be differences between the exposed and unexposed groups that could explain the findings.
Yeah, definitely.
Thank you.
Hi, Erin Vogel. It's a really interesting talk. Thank you. I'm also curious about the comparison group. Do you have any thoughts on how other changes to the ACA besides Medicaid expansion might have affected smoking cessation services in that group, such as employer plans being required to cover some services?
Yeah, I would definitely agree with that. So yeah, I think that and then also some of the public health initiatives in the ACA as well. In terms of private insurance, employer-based insurance, the ACA largely, I think, left that a lot of that untouched. But in terms of the people with private plans who gained them through exchanges and then maybe later went on to their an employer plan. Yeah, definitely. It's really interesting. And again, this is kind of what we wanted to look at in future research is what their CDC actually collects data on what services are actually provided in each state, private plans, exchange plans, employer provided plans. It's interesting to see there's a lot of discrepancies in between that, like you were saying. So yeah, good point.
Any other questions from anyone? Okay.
Thank you so much, guys.